now into part 2. And for part 2, we're going to talk about visual acuity testing and refractive error, and then we'll work into correcting refractive error with glasses, contact lenses, intraocular lenses, and refractive surgery. So for visual acuity testing, we want to know a little bit about visual angle, the different types of visual acuity, near vision, how to test vision in children, the types of eye charts, and we'll review what causes legal blindness. Or not what causes it, but what defines it. And before we talk about visual acuity, just one more review of some basic geometry, which is that we all know that a degree is 1/360th of a circle. But then if you blow up a degree and break it up into 60 pieces, then that's 1 minute of arc. And if you take 1 minute of arc and break that up into 60 pieces, that's 1 second of arc. So 1 second of arc is 1/60th of a 60th of a degree, or 1/3600th of a degree is a second of arc. What are the types of visual acuity? There are 3 types. There's minimum visible, minimum resolvable, and Vernier acuity. Minimum visible acuity is just your ability to see a spot on the wall without necessarily defining what that spot is. And your resolution of the resolving power of the eye for just seeing a dot of dirt on the wall is 10 seconds of arc. Minimum resolvable acuity, that is your ability to recognize a letter, to tell that an E is an E and not something else, is 1 minute of arc, or 60 seconds of arc. So to see a 20/20 you have to have 60 seconds of arc. And then Vernier acuity is your ability to see a break in a line. So this may project differently to different parts of the room, but you see on the right side, these lines have a break in them. And your ability to perceive that break, that's your Vernier acuity. And Vernier acuity is the resolving power there is 2 to 3 seconds of arc. Not 2 to 3 minutes, 2 to 3 seconds of arc. That's finer, that's less than the separation of photoreceptors in your retina. It's exquisitely sensitive, and it's the kind of visual acuity that's used then when adjusting an instrument. For example, you turn a knob until the 2 lines exactly line up, because that's using your Vernier acuity to find that endpoint. In old manual focus cameras, they had a split screen focus, and that split screen was because it was using your Vernier acuity to get that last little bit of resolution. How can it be that you can see with more resolution than the separation of your photoreceptors? Well, it probably has something to do with the ganglion cells and the other cells in the retina that do computations, that figure out this angle, and they anticipate that the angle should be a certain amount, and by averaging over space, it can do that, make that decision. What are the dimensions of the letter E that's used to measure vision? Well, a 20/20 is 8.73 millimeters tall. Each leg is 1.75 millimeters tall. But more importantly, a 20/20 subtends 5 minutes of visual angle, with each leg subtending 1 minute of visual angle. Because again, remember, we said the resolving power of a 20/20 is 1 minute of arc. So that's how you can see those different legs. Now, as a result, if a 20/20 subtends 5 minutes of visual angle, a 2200 subtends 10 times that, or 50 minutes of visual angle. And what that means is something that you know intuitively as well, is a patient with 2200 visual acuity, for example, can't read the 20/20 line. They can read it if they stand 2 feet away, because 2/20 vision is the same as 20/200 vision. It's all a matter of the angles of light and the resolving power of the eye. So what happens then if you have a patient who cannot see a standard Snellen visual acuity chart? Well, you move the patient and the chart closer together, so that a 20/30 optotype at 5 feet is going to be 5/30 vision, which is 5/30 is the same as 20/120. Now, if you'd had a normal, if you had just had the patient at standard distance, they would have seen the 2200 letter, but they wouldn't have seen the 2100 letter, so you would have said they have 2200 vision, but in fact they have 20/120 vision. If you can't record, no matter how close you move the patient, then you have to use other methods such as counting fingers and hand motion, more qualitative assessments of visual acuity. But usually you can get a big enough eye chart that's close enough to get some measurement, if they have it. For near vision, we use reduced Snellen acuity or a Jaeger type or a point type with a near reading card. What's key here is that it has to be at a noted distance. That is, these cards are defined to be used at a certain distance. And you can get big errors if you don't control that. So if you think about if an eye chart's 20 feet away and the patient leans forward a little bit or back a little bit, well, you might get a little bit of error. But if an eye chart is supposed to be held, 28 inches away and they're actually holding it 14 inches away, or if it's supposed to be held 14 inches away and they're holding it 7 inches away, then you're going to get big errors in visual acuity. And I once had a patient referred to me for possible malingering because she had 100 vision at distance, but 20/20 vision at near. And I went through this thumb screw visual acuity where Simmons-Lascelles calls it a thumb screw visual acuity. You start them at 20/15 and you say, can you see any of the letters? And say, no, I can't see any. Well, do you see the dots? No, I don't see any dots. And so then, I'll show you the bigger ones. And you show the 20/20, and they still ask them, and they still can't see them. And say, okay, I'm going to show you the bigger ones. And you show the 20/25 letter. And, you don't see any dots or anything? No, I can't see them. So I'll show you the really big ones. And usually most kids who are faking it will give in by 20/25 or so. But at this one, we marched all the way up to 2100. And that was the one that she could see. And then and then I moved her half the distance to the eye chart, and she was able to see the 20/50 line. And I thought, well, that's pretty good because some of the residents have trouble figuring out which ones she'd be able to see. So I doubt that she'd be able to figure it out on her own. And then I had her read the near, because 10/50 is 20/100. You see, so it all worked. So then I gave her the near card, and she held it 5 centimeters from her face and read the 20/20 line. And so that was, once we held it at the proper distance, it was 20/100. She ended up she wasn't faking it. She had just early Stargardt's, and later that was confirmed. So that's visual acuity in adults. And then in children, I wanted to at least mention testing visual acuity in kids. And just remember, there's only one thing you really need to know about babies. They can smell fear. So when working on testing visual acuity in kids, the first thing to think about is not to let the child know that you're scared. That you need to somehow get information out of this creature, this alien space creature, and find out whether or not he can see. So what do we do? Well, first, just an aside, we do want to be sure that the eye is properly occluded with a good patch. If you try to use a cover like this, you turn your back on them for a second to point at the letter, the cover comes away and they're gonna peek. But here in this case, an actual case of mine is a patient who I couldn't do retinoscopy or anything in this eye, but yet in the page it said she had 20/20 vision. And you see she had a patch on, but she was squeezing and turning her head so she could peek. So you have to be a strict disciplinarian and have them sit up straight and hold their head straight and put the patch on their eye and push it down on the nose so that they're not peeking when you have them have them read. And actually I should say that again, although I do have a background in some engineering background, et cetera, I do actually take care of live patients. I take care of kids and adults with strabismus, and I do refractions, and so I have some clinical experience that I bring to bear on this. Objection to occlusion, of course, is not a quantifiable way, but here he's crying. Here he's fine with the patch over one eye. You put it over the other eye, and the hat comes off, and he's lying on the ground, and he's crying. So you have to worry that maybe he has poor vision in that eye, or maybe in this case you put this funny patch on and poking him in the eye, but because he ended up having fine vision in both eyes. So, and then one of the earliest things that we can see is optokinetic nystagmus, some response to a moving target. So you can use the OKN drum, for example, and look for that movement of the eye in response to a moving target. This, for those of you who are confused, this is the OKN drum, and this is the patient. Then we just look at fixation and following, the ability to track. Again, it's not quantitative, but we can check that. A baby's not going to have fixation and following vision. You can just say blinks to light or something to that, or pupils react, but that's all. It's not till older that they'll fixate on a target and track it. Here's one of the earliest ways that we can get some quantifiable visual acuity was with teller acuity cards. There's a person behind that peephole there, and they're deciding whether the baby's looking at this side or this side. And if it matches, if the baby looks towards the stripes and you use smaller and smaller stripes, then you can say that they have that level of visual acuity. Now finally, as they get older, we can get them into picture optotypes, whether the Allen cards or the Leia symbols, and get some Snellen equivalent, which may not be exact, but at least you can compare the left and the right eyes to look for amblyopia. And then letter optotypes. We used to use the tumbling E, but kids would get confused with left and right vision, so now we've gone to the HOTV letters because he doesn't have to know his letters, but he can just match, and that gives us a true Snellen equivalent, much closer to Snellen equivalent. In amblyopic eyes, we do have to be careful to you can't just have them read isolated letters or you'll get a false reading on your visual acuity, so you need either use a line of letters or crowding bars. Either one works fine. So to summarize then, visual acuity responses during life. At birth, you get a pupillary light reflex or blinks to light, and that's about all you can say for the patient. OKN begins to come in fairly early in life, should be there by 6 weeks. Following movements and fixation are more like, should come in, begin to come in as early as a month of age, but you don't get too excited until they're about 3 months old, and you see that. So in summary, to test visual acuity in pre-literate children, we look at blink to light, OKN, fixation and following, or central steady maintain, the PL preferential looking tests, and then finally into picture optotypes, such as Allen figures or the Leia symbols, HOTV, and then and also you can use the illiterate E game, or the Landolt C is used in Europe. Then finally, there's also visually evoked potential testing, which is the only one of all these methods that doesn't require a motor response on the part of the child. In illiterate adults, you'd use the same. This is one of those questions that you know the answer, but you might forget the answer if you're actually asked out of the context of having a patient in front of you. You would use any technique that you use with a child, or you could also have them read the numbers. And this is something we'll touch on a little bit more later, but factors other than disease that can reduce measured visual acuity. That is, so a patient might just need a refraction. And now that may sound obvious because you can test pinhole acuity, but say you've already done your refraction and the patient still can't see. Well, now you can test pinhole acuity above and beyond that to see if the patient needs a refraction. A small pupil we've already mentioned because of diffraction can reduce visual acuity. A very large pupil can also reduce visual acuity by uncovering certain aberrations in the eye. Decreased contrast of the eye chart could also reduce the measured visual acuity. Very young patients don't have 20/20 vision, and you don't expect that till age 5 or 6. And then very old patients without other disease may or may not get the smallest letters on the eye chart. And then the definition of legal blindness in the United States: best corrected vision has to be 2200 or worse, or the field of vision in the better eye is 20 degrees or less. And that doesn't vary by state, so it's a federal definition that you might be expected to know. State driver's license requirements do vary, so it's not something that you're necessarily expected to know for a national exam. And what is the ETDRS acuity chart, and why is it used in large studies that use visual acuity as an outcome? Well, the ETDRS, or Early Treatment for Diabetic Retinopathy study chart, has letters that are of equal viewing difficulty, as opposed to the Snellen chart, which has some are easier and some are harder to see. Each line has 5 letters, which isn't true of this Snellen chart. the spacing between the letters is equal to the letter size on that line. Again, not true here. And the optotypes change in 0.1 log unit increments, so that a 3-line change is a doubling or halving of the visual angle. That way, if a patient goes from the top line to 3 lines down, that's 3-line improvement is the same as a different patient who goes from, say, this middle line to 3 lines below that. Both patients would be considered to have the same outcome, so that's why it's used and can be used in larger studies. So next I want to talk about refractive error, defining it, talk about far points and focal points, how we correct refractive error, and the role of lens effectivity, that is the position of lens in front of the eye. So refractive error, if we go back to the model eye that we talked about earlier this morning, remember how the secondary focal point was on the retina of the model eye? So if the secondary focal point is on the retina, then the patient is ametropic. They have no refractive error if that occurs with accommodation relaxed. On the other hand, if the focal point doesn't fall on the retina, it might fall in front, in which case you have myopia, or behind, in which case you have hyperopia. Why would the focal point fall in front of the retina? Well, either the eye is too strong or it's too long. Either case leads to focal point in front of the retina, whereas in hyperopia, the eye is either too short, axial hyperopia, or it's too weak, there's not enough power. In either case, then the focal point's behind the retina. There you go. Now, there's another way to consider refractive error, and that's by far point. And we get that by turning the light around and seeing what happens to light as we project it through the optics of the eye. Trace the rays. So here's an ametropic eye. We start here in the retina and trace backwards through the optics of the eye. And since this is at the focal point, it's now the primary focal point, since we turn the light around, that's going to be parallel rays of light emerging from the eye. And so the far point is going to be at infinity. So the far point of an ametropic eye is at infinity, whereas if we take a myope, for example, and we trace the optics through the eye, then you see the front of the eye is too strong, or the eye is too long, but just think of it right now, the front of the eye is too strong. And then instead of parallel rays of light coming out, they're going to be converging, so there's going to be some far point somewhere in front of the eye. And that's the farthest away that the eye can see clearly without accommodating. So at least in the case of the myope. So I'm a myope, so if I were to take my glasses off, relax accommodation, then the far point of my eye is where it first comes into focus, so it's going to be somewhere right here. And you can basically take the reciprocal of that to estimate my refractive error. That's far point. So in hyperopia, we trace through the optics of the eye. Now the front of the eye is too weak, and so there's not enough power to get parallel rays of light coming out, so it's diverging rays of light. So where's the far point of this eye? Well, it's nowhere to the left here, so we must create imaginary extensions of the rays of light back to a point of intersection on the other side. We find a virtual far point that's behind the retina in hyperopia. So let's consider then the difference between far points and focal points. Both describe refractive error and both can be useful, but in different contexts. Focal points are measured from the retina and are never more than a few millimeters away. It turns out it's about 1/3 of a millimeter for each diopter of refractive error. Whereas far points are measured from the cornea and they can extend centimeters, meters, off to infinity in an ametropic eye. And it represents the farthest away that a non-accommodating eye can see clearly. So how do we correct that ametropia? So we have a patient who has a refractive error. Well, the way I think of it is, and I'll explain why in a minute, is if you locate the far point of the eye, now you choose a lens whose focal point coincides with the far point. At that point, in that case, then you've corrected the refractive error. So for a myopic eye, here's the far point in front of the eye, and we choose a minus lens whose focal point coincides with the far point of the eye. For a hyperopic patient, you take a plus lens, and you choose a lens whose focal point coincides with the far point. The take-home message of this is that it's not just the power of the lens that matters, but it's the position of the lens in front of the face that matters when you're trying to correct refractive error. It's the power and it's the vertex distance. Both matter. So that's why we're going to talk next about lens effectivity and vertex distance of plus lenses and minus lenses. So let's take a patient. Here's a case where we have a patient who's a plus 10 hyperope. It turns out that if we move a plus lens forward away from the eye, then we get increased effective plus power. And so that you can see that in a practical sense. You might see an aphakic patient who's trying to look at something up close. You might see them drop those glasses down on their face like so, and that's going to give them more plus power. Another way to think of it is that as we move the lens forward, we need to reduce the power to maintain the same correction. Let's look at an example of that. Here we have a patient plus 10 lens. So then this is properly corrected. So we know that the far point of the eye must be 1/10 diopters or 0.1 meters or 10 centimeters away from the lens. So there's the far point. But now if we push that lens forward away from the eye, now the focal point's going to move forward too. So now the refractive error is not corrected anymore. So we have to give a weaker lens here. We have to reduce this, say, to plus 9. Now it's going to have a longer focal length because 1/9 is 0.11 meters or 11 centimeters. And now the far point once again coincides. So to maintain proper distance correction, you would decrease the plus power as the lens moves forward. Now there's a way that you can, there's a semi-intuitive way to help you remember this, and that is that you know that roughly an aphakic patient is going to have a spectacle lens power of, say, 10 to 12 diopters. But then if you were to put them into contact lenses, you know from your clinical experience that a contact lens patient, aphakic, is going to be like about a 15 to 18 diopter contact lens. Or an intraocular lens power is going to be, you know, clinically roughly 18 to 20 diopters for a typical aphakic patient. So by this clinical knowledge, you can sort of work out the fact that the closer you get to the retina, the more power you're going to need to correct the same refractive error. And so in this case, the optician only has one power of plus lens, but just prescribes based on vertex distance. So now this then gives us an opportunity to give you questions that you have to answer, which is to do a vertex distance correction. That is to figure out how to change the power of a lens given that it's going to move, say, from the spectacle plane to the contact lens plane or vice versa. And there's 3 steps to do that. First, you figure out the focal point of the present lens because that tells you where the far point of the eye is. Then you calculate the distance of the new lens from the far point. And then you take a reciprocal of that new distance because that's going to be the power of the new lens. So let's look at an example. So a patient comes into your office wearing a plus 12.5 diopter spectacle lenses with a vertex distance measurement of 13 millimeters. The patient wishes to have contact lenses. What power contact lens would you likely need? Well, we go to the first rule of optics, which is when in doubt, take a reciprocal. And in this case, we're going to take a reciprocal of the 12.5 diopter lens, which is 0.08 meters or 8 centimeters. And yes, that tells us that the far point of the eye is 8 centimeters behind the lens, behind this lens. Now the new lens is going to be 13 millimeters closer to the far point. So here's the new lens. It's a contact lens. So we're going to subtract 80 millimeters minus 13 millimeters, and that gives us 67 millimeters. So what power lens do we need to have a focal point that falls on the far point of the eye, that is a focal length of 67 millimeters? Take a reciprocal. 1/0.67 meters is 15 diopters. So it's just 3 steps to get to that answer. There are books and formulas that you can, there are formulas out there that can do the correction for you, but I think it's best to just take it in step by step like this to work it out. So for minus lenses, it's kind of the same, but kind of the opposite. That is, moving a minus lens forward will decrease its effective minus power, but that's the same as adding plus power. So whereas moving a minus lens toward the eye increases the effective minus power. And this is the one place in optics where people who wear glasses have a slight advantage over those who don't when taking a test, because I remember I was taking the exam, and again, like I say, this didn't come naturally to me, and so there was a question about this very topic, and so I was taking my glasses and sort of sliding them down on my face to see, and then I look around the room and I see 2 or 3 other people in glasses are going like this, and what I was seeing was less and less, less minus power as I went away. Another way to remember it is that is to think of somebody, myopic patient, myopes more common, sitting on the beach, and their glasses are kind of down on their face, and then someone walks by that's of interest to them. What are they going to do? They push the glasses up on the nose to get that full minus correction. So next, let's go to accommodating and prescribing bifocals. We'll talk about the physical properties of accommodation, how to measure it, how to prescribe bifocals, and the different types of hyperopia. So accommodation is an increased convexity of the lens that adds plus power to the eye. We'll consider it as acting at the cornea. So in other words, here's the basic Helmholtz theory of accommodation, which is that you have some object and you have the plane of the retina and you want it to be in focus on the retina, and here's the lens. Now, notice that as we move into, up until now, we've been considering objects at infinity. That's parallel rays of light coming into the eye. Now we're considering an object closer, so it's diverging light coming into the eye. So how do you get more power? Well, the zonules are tight on the lens. They're keeping it flat. So the ciliary muscle contracts, the zonules loosen, and the lens takes up more of a round shape, so it gains more plus power, and the image moves closer, like so. So ciliary body's relaxed, the image is back there. Ciliary body contracts, the zonules relax, the lens becomes more round, the lens becomes more powerful. That's what puts the image on the retina in accommodation. So this physical ability of the lens to change shape is the accommodative amplitude of the eye. And that's one way to gain accommodation. Now, there is potentially another way to gain accommodation, which we don't use, but some animals do. And there are these accommodating intraocular lenses. And the people who invented this, they must have studied their optics, and they realized about effective lens power. If you could move the lens forward in the eye, you can get more plus power that way rather than making it rounder. So these intraocular lenses have hinges on them, and the theory is that as the ciliary muscle contracts, the vitreous pressure increases, it pushes the lens, this lens forward, and gives some extra plus power. Those are in clinical trials, and so not clear that they're working as well as expected, but it's at least a nice idea. But in most cases, what we're looking at is this change in shape of the lens to get accommodation. So how do you quantify that? Well, first of all, we've already talked about the far point, which I'll define more rigorously now as the point on the visual axis that's conjugate to the retina, you know what that means now, with accommodation completely relaxed. The near point is the point on the visual axis that's conjugate to the retina with accommodation fully active. That's the near point. And the accommodative amplitude is what gives you that difference. So amplitude of accommodation is a number that's expressed in diopters. It's the maximal capacity of the lens to accommodate. There's one other number that we can put on accommodative ability, and that's range of accommodation. It's the distance between, it's 2 numbers, a near and a far distance. And it's the linear extent of clear vision obtainable using accommodation. So how do we measure accommodative amplitude? Well, we take a target and we attach it to a ruler that's scaled in centimeters and diopters, either a Prince rule shown here or a Royal Air Force rule. So there are numbers on that, not just in centimeters, but also in diopters. And then you cover one eye, and you move this target closer and closer, gradually move it closer to the eye, and strongly encourage the patient to keep the target in focus until they can no longer keep it in focus. And at that moment, at that distance, you take the reciprocal of that number, and that's their accommodative amplitude, assuming that you first put their distance correction in place there. Now, in patients who you're measuring accommodative amplitude, they're probably not going to be that good at accommodating in the first place, so you might have to give them a little boost. That is, you don't start with the distance correction. You would start with, say, a +3 add. So how far away would the target be in focus with a +3 add? 1/3 diopters, 33 centimeters. So you'd start this, you'd dial the +3 in, start this at 3 diopters or 33 centimeters away, then you start moving it closer until it goes out of focus. Say it goes out of focus at 4 diopters or at 25 centimeters, then their accommodative amplitude is just 1 diopter. So let's look at some examples of this. Here's a patient who has 4 diopters of hyperopia and an 8 diopter amplitude of accommodation. So in order for this person to see clearly at distance, they have to use up 4 out of their 8 diopters of accommodative amplitude just to see clearly at infinity. So that leaves them 4 diopters left over to apply now to bringing the target in as you move the target in closer. So their near point is going to be 1 divided by 4 diopters, or 25 centimeters away. So their range of accommodation is going to be from infinity up to 25 centimeters away. Now let's look at a second patient who also has an 8 diopter amplitude of accommodation, but now has 4 diopters of myopia to start with. In that case, the far point, the point with accommodation fully relaxed, is going to be, there are 4 diopter myopes, so it's going to be 1/4 diopters, or 25 centimeters away. That gives them a 4 diopter head start, as so to speak, on accommodation. So we take the 4 that's already built into their eye plus 8 that they can apply, and that's 12 diopters total. 1/12 diopters is 0.083 meters, or 8.3 centimeters away. So the range of accommodation of a 4 diopter myope who has an 8 diopter amplitude of accommodation is from 25 centimeters up to 8.3 centimeters away. In both cases, if you give them their proper correction for distance, then they're going to have a near point that's 1/8 diopters away, 12.5 centimeters, because that's their amplitude of accommodation. So now, so how often then do we do this? I mean, you have a patient, they're 42 years old, they're having trouble reading, and are you going to map out their amplitude of accommodation for each eye and figure out where their far point is and their near point with and without correction or through a bifocal or not? You know, are you going to do all that for your average patient? No. All you're really going to do is, you can use a table, or you can just do trial and error in the office, or use your clinical experience to estimate and put something up there, because not every patient needs that kind of a rigorous evaluation. But every now and then you'll have a patient who has asymmetric accommodation, who's prematurely presbyopic, who has some other refractive issue or consideration where you need to know how to be able to do this and assess it in order to help them. Finally, what are the 4 types of hyperopia? This is something I have to review every time I look at it, but they're absolute, manifest, facultative, and latent. And rather than just go through the definitions, let's just go straight to an example. A patient requires +1 diopter to see at distance. I hear flipping around. Does that mean it's not in the notes? So it must mean that it's probably in the notes but lost or misplaced. So it should be there somewhere. So I apologize because I'm hearing the flipping noise. A patient requires +1 diopters to see at distance. The manifest refraction reveals that she'll tolerate up to +2 diopters, and the cycloplegic refraction is +5 diopter sphere. What are the types of hyperopia in this eye? Well, she requires +1 to see at distance, so her absolute hyperopia is 1 diopter. But she'll accept up to 2 diopters, so she has so the manifest hyperopia is +2, and the facultative hyperopia, that is the ability to shift to still be in focus. She has a facility to keep things in focus of 1 diopter, 2 minus 1. Then the cycloplegic or total hyperopia is 5 diopters, and so the latent hyperopia, that only shows up under testing conditions, is 5 minus 2, or 3 diopters. So that's accommodation and hyperopia. And next, let's talk about astigmatism. And we'll talk about, define a cylindrical lens, the conoid of Sturm and circle of least confusion. We'll look at power crosses and describe types of astigmatism. Look at spherical equivalent and what happens with tight sutures and distortion. So here is your cylindrical lens that's used to correct or cause astigmatism. And that lens, you see, is why it's called a cylindrical lens, is because it looks like a cylinder. So what happens to light as it encounters this cylindrical lens? Well, rather than thinking of light as just a beam of light, I want you to think about light as a whole bunch of vertical planes of light, all one next to each other. And we're going to take one of those vertical planes of light, and what does it encounter as it sees this lens? It's actually easier if I just walk in front of the in front of this picture for a minute. So we have a vertical plane of light, and what it's going to see is it's going to see a flat surface. So it's just going to pass on through that lens. It'll slow down, it'll speed up, but it'll just go off. It won't get refracted at all. But if we have a horizontal plane of light, then that horizontal plane of light is going to see a curved surface. It's going to get refracted to a point over here and then go off. And if we take another horizontal plane of light above that, it's going to get refracted to a point as well. And another one below that, it gets refracted to the same point as well. And so if we have an infinite number of horizontal planes of light constituting a beam of light, they get refracted into a focal line. And the focal line is parallel to the axis, but perpendicular to the power of the lens. So that is a cylindrical lens. Now, what happens if we want to add a little bit of power to the vertical part of this lens as well? Then we have a spherocylindrical lens, which I show here. Now we have the one focal line from the horizontal power, but now the vertical curvature also gives us a second focal line over here. That distance between those two focal lines, is the vertical and horizontal focal line, is the interval of Sturm. And the geometric figure that's formed by the rays of light as they go from one to the other are called the conoid of Sturm. The circle of least confusion is the circular cross-section of the conoid of Sturm that's halfway in diopters between those two focal lines. So if this focal line is 4 diopters or 25 centimeters away, and this one's 2 diopters or 50 centimeters away, then this one's going to be halfway in diopters, so it's going to be 3 diopters or 33 centimeters away. And why do we call it the circle of least confusion? Well, it's where there's least distortion of the letters as you try to read them. So here we are in the vertical focal plane. You see the horizontal lines are smeared, but the vertical stays okay. Over here, we're on the horizontal image plane, and the vertical lines get smeared out, but the horizontal lines are okay. But in between, yes, there's distortion, but it's equal vertical and horizontal, so the shape of the letter is best preserved, thus the name circle of least confusion. So in an astigmatic eye, you can have then not just a focal point in front or behind the retina, but you have 2 focal lines now, in this case in front of the retina. And you can correct an astigmatic eye, and you can also have just as you can have a focal point turns into 2 focal lines, the far point of the eye in an astigmatic eye turns into 2 far lines. And you can correct the refractive error in the astigmatic eye by choosing a lens whose focal lines coincide with the far lines of the eye. Now the direction of the astigmatic axis is the same in the right and the left eye. It's not symmetric, it's identical. So, and it's every 30 degrees is another clock hour on the astigmatic lens. So how do we then describe a lens that has different powers in 2 meridians 90 degrees away from each other? you can't just use a single number. You need two numbers and an orientation. So one way to do it is with a cross diagram. And in this case, we have a cross with principal meridians labeled with the power acting in these meridians. So we have +1 here acting in the 135-degree meridian and +3 acting in the 45-degree meridian. That's a power cross. Now, we can also, though, talk about the axis, because remember I showed how axis is 90 degrees away from power. So the axis cross would be +1 axis 45 and +3 axis 135. These are the identical lens. One's a power cross, one's an axis cross. So, but that can be a little bit cumbersome to try to use these cross diagrams to describe glasses. And we all know that when we have a glasses prescription, that's a sphere and cylinder in there. And we can write it down with some numbers. So how do we get to that at that point? Well, I'm going to go through an example to show you how to do that. So a patient comes into the so you have this cross diagram where you have -1 in the 180 meridian and +2 in the 90-degree meridian, which, by the way, could be the result of a stenopeic slit refraction, which we'll talk about briefly later. Stenopeic slit refraction gives you these two numbers. How do you convert that to a glasses prescription? Well, first, we know that this is a combination of two cylinder lenses, so we can draw it that way. It's +2 on the 90, and it's -1 on the 180 meridian, and this is the combined with symbol. Now let's add across meridians, make sure we did it right. 0 + 2 is 2. -1 + 0 is -1. So that combination is exactly the same. So we can write that out in numbers. This is +2 in the 90-degree meridian, or +2 axis 180. And this is combined with -1 in the 180 meridian, or -1 axis 90. But that still doesn't look right. It doesn't look like a glasses prescription, and that's because it's just a combination of cylinders. We want spherocylindrical notation, a sphere and a cylinder. So to do that, we have to make one of these two crosses into a sphere. Let's make this one into a sphere. So how do we do that? Well, we're going to give it +2 in the horizontal meridian. But what we give to this side, we must take away from this side. So if we give +2 to this side, we have to take away +2 from this side. So -1 minus 2 is -3. So now we have +2 sphere combined with -3 in the 180 meridian, or -1 axis 90. And there's our spherocylindrical notation, +2 minus 3 times 90. Now we could have, instead of making the +2 into the sphere, we could have made the -1 into the sphere. So let's try that. So we put a -1 in the vertical meridian, like so. But what we give to this side, we must take away from this side. So +2 minus -1 is +2 plus 1 is +3. So it's -1 sphere combined with +3 in the 90-degree meridian, or +3 axis 180. And that's plus cylinder form. So that's how you make that transition. Now we also want to know, how do we go backwards the other way? How do you take a glasses prescription and make it into a power cross? So let's look at that. One very straightforward way to do it is to draw two power crosses. So you're given a prescription, +2 minus 3 times 90. Draw a power cross to represent that prescription. Okay, you say, we'll take +2 and we'll put it here on a power cross, +2 plus 2, give a combined with symbol, and then we have -3 axis 90, which is -3 in the 180 meridian. Now we add across meridians to get it into a single power cross. 0 plus 2 is 2. -3 plus -2 is -1. And there's our power cross. And we can go back. We can go back to the other, and it's the same as what we just showed over here. Now there's another way to do it that's actually a little faster and requires even less thought, if you can remember how to do it. And that is, you write out the prescription in both plus and minus cylinder notation. So you're given this prescription. Let's also write it out in minus cylinder notation, so I'll jump ahead a little bit. How do you convert this to minus cylinder? The new sphere is the old sphere plus the old cylinder. So +2 minus 3 is -1. The new sphere is the new cylinder is the same as the old cylinder, but with opposite sign. And the new axis is 90 degrees away from the old axis. So this is the same prescription written in minus cylinder form and in plus cylinder form. Once you've done that, it turns out it sort of just works out this way, that you can go straight to the power cross. You take the sphere on this one and put it on the axis here, like so. And you take the sphere in this one and you put it on the other axis, like so. Just, I think a student pointed this out to me once in one of the lectures, but it's a quick way to get there without really having to think it through much further than that. And it just works out. And it's not an axis cross, it's direct to the power cross. So that gives us the same result. So as I just said, to transpose from plus to minus cylinder, new sphere is the old sphere plus the old cylinder. New cylinder is the same as the old cylinder with opposite sign. New axis is 90 degrees away from the old axis. Now when you're doing retinoscopy with free lenses, you're doing retinoscopy and you need to turn that into a glasses prescription. You're not just taking it out of the four-opter, and you're using all spherical lenses. So you need to know how to do that. So say you have a patient and you have the intercept horizontal and you sweep it across the pupil. That's going to give you, and let's say that's neutralized with a plus 2.5 lens. Then you're going to put that direct, you're going to put this as the axis, this is the power, so you're going to put it on the axis cross as a plus 2.5 that matches up with this axis of the intercept. Then you have to do the vertical. And so let's say in this example, you neutralize with a plus 4.5 lens. That means the plus 4.5 is going to go here. And so then to get your final prescription, you write it out. That's plus, you do what we just showed you to convert, to write it out. It turns out that it's plus 2.5 plus 2, axis 90, because it's already an axis cross. But then you do have to subtract your working distance, which if you happen to be working at 2/3 of a meter away, that's going to be 1.5 diopters. So there's your net prescription, plus 2, plus 1, plus 2, axis 90. So you should be able to go from free retinoscopy to writing out the net glasses prescription. Now what happens sometimes, especially in pediatric ophthalmology where we have kids who wear really strong glasses, or if you have a patient who's aphakic, it's ideally you'd like to refract just over those really strong lenses and change and just make little changes rather than put the whole thing into the four-opter, because then you can get errors of addition and vertex distance and all. So we'll sometimes refract over the glasses by putting these Janelli clips on there. They're supposed to be straight up and down. And then now you have a cylinder. So how do you get the new cylinder? Well, one way is there are over-refraction calculators. You see down here you can add the cylinder to this one. But what I do in the office is I then just take the glasses and these clips and the astigmatic lens and put the whole thing in the lens meter. And then you can just read off the whole combination as if it's an unknown glasses power, and that's your net new prescription. Now, sometimes you might be asked to combine cylinders to end up and to figure out sort of generally speaking, maybe not exactly, but the roughly where the combination of those two cylinders end up. And I just want to show you an example of how to do that. So say you have a lens that's plus 1, plus 4.5 like so, and then a second lens is plus 1 and plus 4.5 like so. If you combine those two together, is the net what's the orientation of the net cylindrical power going to be? Well, to figure that out, first of all, we don't care about the sphere, so we're just going to take all the sphere away. So we'll take away 1 from all 4 of these and just sort of put that aside. So the net question really is you've got a 3.5 this way and a 3.5 this way, and what's the combination of those two? To figure it out, we can break it down into the horizontal and the vertical components. So the 3.5 has some horizontal power going to the left and some going up. This one has some horizontal power going to the right and some going up. So if we combine those two together, then you see the horizontals are going to cancel out, but the verticals are going to add up. And that's our net combination then. So the net answer is going to be there's going to be some amount of cylinder rough at 90 degrees. what are the different types of astigmatism? Remember I mentioned that you have two focal lines in an astigmatic eye, and depending on where those focal lines are, that's the type of astigmatism that you're working with. So it can be compound myopic, simple myopic. Compound myopic is if both focal lines are in front. Compound hyperopic is if both are behind. Mixed is if one focal line's in front and one's behind. And then you have rare case of simple myopic or hyperopic where one of the focal lines actually falls on the retina. Now, astigmatism is something that, it's just something about it that patients just, they don't like being told they have astigmatism. They're told they have a stigma in their eye, and they won't remember the fact that they had a stick in their eye or a needle in their eye, but they'll remember that they've got astigmatism. And it's just one of those things. I actually try to avoid using the terms if I don't want to worry a patient. Try to use some other terms, but patients still here. They understand that they have a football in their eye or something. So there are different types of astigmatism. There is with the rule and against the rule. That means with the rule means that the cornea is steeper in the vertical meridian, against is steeper in the horizontal meridian. So why use this kind of odd terminology instead of just saying whether it's vertical or horizontal? Well, part of it is that because we can use either plus cylinder notation or minus cylinder notation, different people use different foreign notations, and so the plus cylinder people have to be able to talk to the minus cylinder people. So if you just say with the rule astigmatism, then everybody knows that that means that the cornea is steeper this way. Tends to be true more in younger patients that you have with the rule astigmatism, probably because their corneas are more pliable, plus their eyelids are more elastic, so that's going to push on the tops and bottoms and cause the middle to bow out. Older patients tend to develop against the rule astigmatism. If the axis of correcting cylinder is not within 20 degrees of the vertical or horizontal, then it's oblique astigmatism instead of plus or minus. And then it can be symmetrical or asymmetrical, depending on the orientation of oblique astigmatism. So, for those of you who are trying to build your refractive surgery practice, you can say, you can present your patient with the results of your refraction and say, well, Mrs. Jones, I'm afraid I have some terrible news. You see, I've discovered that you have astigmatism in your eye. You have astigmatism. Not only do you have astigmatism, but you have compound myopic astigmatism against the rule. But we can fix it with a laser. And thus you'll... that's the thing, is that I actually envisioned that when I was a kid that maybe someday I'd grow up to be a stand-up comedian or something. But here it's better because I can tell my jokes, but if nobody laughs, I still get paid. How do you tell if a patient has compound myopic astigmatism or simple astigmatism or whatever? Well, you simply write the prescription in both plus and minus cylinder form and then look at the spherical power, because those are the two numbers that are going to go on the arms of the power cross. And if both arms are positive, it's compound hyperopic. If both arms are negative, it's compound myopic, etc. So we can look at a couple of examples. Here's a patient. We write out the prescription. Here it is in plus cylinder notation. We write it out in minus cylinder notation. You see this one's going to be plus and a minus on the power cross, so that's mixed astigmatism. This is going to be a plus and a plano on the power cross. That's simple hyperopic. Those are both plus, so that's compound hyperopic. So spherical equivalent is just the average power of a spherocylindrical lens, and it's equal to sphere plus half the cylinder. That number, the spherical equivalent, is what places the circle of least confusion on the retina. So let's look at an example. What's the spherical equivalent of minus 1 plus 2 times 45? Well, it's the sphere, which is minus 1, plus half of the cylinder, plus 2. And the combination is plus 2 divided by 2 is plus 1. So negative 1 plus 1 is 0. So the spherical equivalent of this lens is plano. And in fact, that's the prescription for a 1 diopter Jackson cross cylinder. with the axis depending on how you hold the Jackson cross cylinder, and we'll talk about Jackson cross cylinders a little bit more later. But they have planospherical equivalent, which is key. Now here's one that comes up and that I like you to know about because I think that it can have clinical implications. A patient has keratometry of 40 in the 30-degree meridian, 46 in the 120-degree meridian. What is sort of astigmatic correction would you expect to see? Again, I hear a little bit of flipping of pages, but I'm pretty sure it's in the notes. If not there, then it might have got lost. So the answer to figure this out is that you see there's 6 diopters between the two meridians, 6 diopters of cylinder. So and furthermore, the 120-degree meridian is the steepest. So to fix that, you would want to put minus 6 diopters. One way to fix it would be put minus 6 in the 120 meridian. So therefore, minus 6 in the 120-degree meridian would be minus 6 axis 30. Therefore, one way to correct this, the astigmatic part of this refractive error would be minus 6 axis 30. So if you look at the glasses prescription and you're not seeing minus 6 axis 30, roughly, it's not exact because it depends on the vertex distance, for example. But if you don't see about minus 6 axis 30, then that means that it's not all corneal astigmatism. It means that there's some lenticular astigmatism in there as well. And so if you're planning refractive surgery on a patient and the corneal astigmatism isn't corresponding to the refractive error, then you could end up in trouble if you take away all that corneal astigmatism. There's a way that disregards the spherical part of the correction, but the focus here is on the cylindrical part. So if you have a patient who has tight sutures, how exactly does that lead to astigmatism? And that always was a mystery to me for many years, until I taught this course for a few years and finally figured it out. Here's a patient who's had corneal surgery and the sutures tie just the right tension, and so there's no distortion of the cornea at all. Now, in my view, it seemed to me that if you tie that suture too tight, it's going to make the cornea flatter, but everyone told me, no, the tight suture makes it steeper in that meridian, and the attending would say, no, cut the high K, cut the suture where the K is the highest. And so I finally figured out that, yeah, that I was kind of right, but so was everyone else. So a tight suture does flatten the cornea, but it flattens the cornea where the suture is, and then you get a compensatory steepening of the rest of the cornea. And the compensatory steepening happens over the pupil, and that's the only part that matters for refraction is what's going on over the pupil. So that's why you end up with a steep cornea from a tight suture. You cut the suture, that allows this to flatten, to steepen, and you get a compensatory flattening in the center. There are other aberrations in the eye that I want to mention, important aberrations, 2 in particular, spherical aberration and astigmatism of oblique incidence. Spherical aberrations where the peripheral rays are refracted more strongly than paraxial rays. So that in this example I have here with a biconvex lens, the central rays, they don't see as much curvature. The peripheral rays see more curvature, so they get refracted more strongly. So now you end up with these aberrations that cause distortion and reduce the best visual acuity. Where is that clinically important? Well, we see it when we're doing retinoscopy, especially in young kids whose pupils dilate widely. I don't know if you've seen this before, but you'll see with movement centrally, but you'll see against movement peripherally, and then you don't really know, well, which part of the refraction am I trying to neutralize here? The reason that happens is that because of spherical aberration, where there's just the lens is stronger in the periphery than it is in the center. The practical outcome is that you want to concentrate your refraction on the center of the pupil, because that's the part that's still going to be exposed once dilation wears off. There are ways to make lenses that reduce the spherical aberration. For example, spectacle lenses have this sort of meniscus shape that reduces it, or your indirect ophthalmoscope lens has what's called an aspheric lens surface. But those lenses are designed to be used only one way. So if you've ever, you have this white ring and you're not supposed to have the white ring showing when you're examining the patient, and that's because of spherical aberration. You see the severe spherical aberration when the lens is held upside down. You get much more magnification out here in the periphery, whereas it's nice and flat all the way across when you use the lens in its proper manner. Astigmatism of oblique incidence is what you get when you tilt a lens. So tilting a spherical lens induces astigmatism. Tilting a plus lens gives you plus cylinder with the axis and the axis of tilt. And tilting a minus lens gives you minus cylinder with the axis in the axis of tilt. You also get a little bit of sphere to the same degree. So you may have, I don't know if you've ever noticed, you sort of look in the back of an audience and you might see a patient, probably nearsighted, and they've kind of got their glasses sort of tipped up like this. Are they trying to get more astigmatism correction? No, but they're getting that little bit more of sphere as well. They're probably under minus, so their glasses need to be a little stronger. You can sort of diagnose that they're under minus because they're tilting their glasses up like on the beach. So there's two things to get more minus power. There's the person on the beach and they're pushing their glasses up like so. But then if they want to get even more minus power, you'd go like this. But that looks goofy, so nobody's going to do this on the beach. Where else do you see that a small amount of sphere? The same sign is induced. Undercorrected myopes tilt their glasses, gaining cylinder and sphere. The other clinical take-home of that is that if you try to do retinoscopy from the side, you'll get against the rule of astigmatism. And you can work this out if you sit down and think about it. But the lens, there's a 60 diopters of plus power in the eye. And if you go get oblique to that, then you're going to get plus cylinder induced in the axis of tilt. And so then you're going to have to correct that with plus cylinder opposite of the axis of tilt, which is going to have the with axis opposite the axis of tilt. Let's next talk about the differential diagnosis of various refractive errors as a way to sort of bring together some of these thoughts about effective lens power, axial length, and how it contributes to refractive error. And this is one of the ways, too, that a clinical scenario can be used to sort of probe your understanding of optics. So a patient comes into the office who has an increase in their myopic correction, progressive increase in their myopia. And why might that be? Well, one cause of progressive myopia could be what's shown here is keratoconus. Keratoconus, the cornea becomes steeper, the eye becomes stronger, the eye becomes more myopic. Notice this cornea is steep enough that you can almost sort of see the angle structures. Another cause, here's a baby with big, beautiful eyes, but maybe they're too big and maybe they're too beautiful. In fact, this patient has 20 diopters of myopia because the eyes are enlarged from glaucoma. And there are patients who have, I've seen malpractice cases where kids come in for tear duct, they get recurrent tear duct probings, but no one ever does a refraction. No one ever looks at the optic disc, and it turns out that they're congenital glaucoma patients and they're tearing for that reason. So myopia, progressive myopia from increased axial length can also be a factor. And I use this in my aphakic children because I can't always check their pressure. And so, but if I see a myopic shift, then that might push me over the edge to get an exam under anesthesia. So this congenital glaucoma was missed. This one would be harder to miss. Differential diagnosis of acquired myopia then. Things that make the eye too strong, increased refractive power of the eye, and that would include keratoconus. Lens changes such as cataract, lens dislocation anteriorly. Cataract can cause increased myopia both from changing the shape of the lens, but also by changing the refractive index of the lens, because a cataractus lens has a higher refractive index. Diabetic changes as well. The lens can swell and become more round or get a higher refractive index, or excessive accommodation, accommodative spasm, inadequate fogging by the examiner. So things that make the eye too strong, or things that make the eye, drugs, miotics, Topamax, anything that pushes the lens iris diaphragm forward is going to make the lens stronger inside the eye and cause a myopic shift. Or things that make the eye too long, and that could include a posterior staphyloma, congenital glaucoma, a scleral buckle. Pull that scleral buckle on nice and tight, make the eye 1 millimeter longer or 2 millimeters longer. That's going to be 6 diopters of myopia. Here's something that makes a patient that comes into your office and they've had a hyperopic shift. And you say, well, that's odd. You know, I don't usually see patients become more hyperopic. And you think, I wonder what could cause that. And you had sort of passed on the retinal exam the first time, but then you say, you know, maybe I better just double check. And you look again and you see there's choroidal folds. And the choroidal folds are because there's something pushing the eye forward and making the eye shorter. There's a tumor behind the eye. So here you've used your knowledge of optics to maybe save the patient's life by diagnosing a tumor in the orbit. Another thing that can make the eye shorter would be central serous retinopathy, which doesn't make the eye shorter, but it pushes the retina forward under this layer of clear subretinal fluid. One of the hallmark features of central serous retinopathy is a hyperopic shift. So things that can cause acquired hyperopia would be things that make the eye too weak, decreased refractive power of the eye, lens changes, anything that would dislocate the lens posteriorly within the eye, or aphakia, of course. Poor accommodation through drugs, 80s tonic pupil trauma to the eye, definitely seen that regularly. Chloroquine, or any drug that can interfere with accommodative ability, can also reduce the refractive power of the eye and cause what appears to be acquired hyperopia. Or things that make the eye shorter, including a tumor, choroidal or orbital tumor, or decreased effective axial length with central serous retinopathy. And then there's the matter of acquired astigmatism. A patient comes into your office and they have more astigmatism than they had on the last visit. What could cause that? Well, here there's a pterygium that's sort of pushing on the cornea to the side and causing it to warp centrally. Here's a patient with Terrien's degeneration that's causing the corneal changes over the pupil as well and more astigmatism. Here's a patient with the posterior lenticonus that causes both myopic change but can also cause astigmatism. So what can cause astigmatism in the eye, progressive in particular? It can be corneal causes or lenticular causes. Corneal causes would include just simple astigmatism. Anything pushing on the eye, didn't show a picture, but we've seen, we use this as a decision whether to operate on a child with a hemangioma of the eyelid. If it's pushing on the cornea enough to cause astigmatism, then we'll be more aggressive with it. A chalazion can do it too, a tumor, even just congenital ptosis, you can get more astigmatism as a result. Structural abnormalities, keratoconus, like I showed earlier, that not only makes the eye too strong, but also adds an astigmatic error. Terriens or pellucid marginal degeneration, or lenticular astigmatism. So lens causes would include simple lenticular astigmatism. Lenticonus, as I showed, lens dislocation off to the side instead of to and fro. A lens coloboma could cause it, or a ciliary tumor. The first sign of a ciliary tumor could be a change in the stigmatism as a result of the tumor pushing on the eye. I just saw a patient the other day, and he has pretty severe form of Marfan's, but he has hardly any zonules, and so instead of his lens being dislocated to the side, where Marfan's is pretty typical to see side lens dislocation, this patient's lens is just unsteady in the eye, and some days his chamber's kind of shallow, and other days his chamber's deep. When it's deep, you see iridodonesis. When it's shallow, he gets like 5 more diopters of myopia, but the iris doesn't wiggle. So he's going to get the lenses taken out, but right now he's in that state. That's a ciliary tumor that can push on the lens and cause acquired astigmatism. So that's differential diagnosis for refractive error. Now we want to talk about correcting refractive error through contact lenses, refractive surgery, and intraocular lenses. Let's talk about contact lenses first. They'll talk about the clinical evaluation, power calculation, evaluating the fit, and then again I'll come back to comparing keratometry with refraction because it matters. So when we're fitting a patient for contact lenses, we want to look at the corneal contour, we want to assess the tear film, look for eyelid abnormalities, look in advance to see if they have any signs already of papillary conjunctivitis, and look for eccentric pupil. But mostly what I want to focus on is the refraction and the fitting. For the refraction, you could just put on a trial lens and then refract over that, and that's probably the way it's mostly done. Or you could calculate the whole thing. You do need to perform a vertex distance correction, and you should compare the keratometry with your refraction to look for lenticular astigmatism. So say you have a patient coming into the office who wants hard contact lenses, and you don't have any trial lenses available. Is there a way to calculate the lens power that you might, and shape, curve that you might use to correct that patient's refractive error? Yes, it can be done, and you do it. There's a few steps to it. You need the refraction and the keratometry readings, and then you're going to choose a lens whose base curve is steeper than the flatter K, a half diopter steeper. Now, what does that mean? We want to choose a contact lens that's going to match the curvature of the cornea. And so if you think about trying to match a curve that's, if the whole cornea is spherical, that's easy. You have just one number. But if part of the cornea is steeper than the other, say it's steeper in front and behind and flatter to the side, then you're going to want to actually match the flatter side. So imagine that I'm standing on a mountaintop, and the mountaintop is sort of flatter side to side, but it's steeper front and back. Well, and I want to choose something that's relatively stable to stand on. I'm going to choose a curve that matches the flatter surface, and then the steeper is going to drop off in front and behind. That seems to work best. Then what happens in the eye is that there's not somebody standing there, but what happens is the tears come in then and fill the gap on the steeper side. So the take-home message of that is we choose a base curve that's steeper than the lower K, but you can't have it exactly matching because then there's no room for tears, so you want to vault it by a half diopter over the surface of the cornea. So you choose a lens that's 0.5 diopters steeper than the flat K. Then you convert the refraction to minus cylinder form and to zero vertex distance. And we can disregard the minus cylinder because those tears that fill in under that fill in those spaces where it's steep, those are like a minus cylinder lens. And then we finally have to subtract the tear lens from what's ground into the front of the surface because that little vaulting actually adds a little plus power behind the lens. So let's look at an example. Patient comes into your office with a refraction of plus 11.5 plus 1 times 35 at 13 millimeter vertex distance with keratometry of 44.25 and 45.87. What contact lens do you estimate, hard contact lens, could correct the refractive error? Well, the first step is we want to choose a hard lens whose base curve is just above the lower K. So the flat K is 44.25. We add 0.5 to that to vault over the cornea. And so our base curve is going to be 44.75 diopters, which you could convert to a radius of curvature if you have a converter, just a reciprocal, basically. Then you convert the refraction to minus cylinder form. So here's the plus cylinder form. New sphere is the old sphere plus the old cylinder, so 11.5 plus 1 is 12.5. New cylinder, same as the old cylinder, but with minus power. New axis, 90 degrees away from the old axis. Now we disregard the minus cylinder. Just throw that away, and so 12.5. So is 12.5 the power that we're going to need? No, because that's at 13 millimeter vertex distance. We need to convert to zero vertex distance, so we take a reciprocal at 12.5. That gives us a number. We subtract 13 from that. We take the reciprocal of the new number. The reciprocal of the new number is 15. So is that the power that you grind into the front of the contact lens? Not quite, because remember we vaulted a half diopter over the cornea, so we've got to take a half diopter off of what's ground into the front of the lens, but it'll be a 14.5 diopter, 44.75 base curve lens. Then how do you look at it and evaluate the fit? Well, the basic thing you want to look for is that you want to see that you can put fluorescein in the eye with hard lenses, and you want to see that the tears are filling in that little bit of gap. Here, the lens is too flat, and so you can see apical touch with pooling above. That's going to be an uncomfortable lens because the eye is starving for oxygen right there. This is an eye with astigmatism, and this is what I was saying to you before. Here's the flat meridian, the lens fits that way. Here's the steep meridian, and the tears go in to fill up that space. I really like that picture because it shows that astigmatic lens filling in. Kind of makes sense. You replace the warped cornea with a clear cornea, the astigmatism will go away. That's how you assess fit with a hard lens. What about a soft lens? You can't put fluorescein in the eye with a soft lens or it ends up staining the lens. In that case, you evaluate the movement of the lens with a blink. If the lens moves too much with a blink, then it's too flat. If it doesn't move enough, it's too steep. It's the difference between having just a piece of saran wrap in the eye. You can imagine that's going to move around a lot when the patient blinks because it's too flat. Whereas if you have a little suction cup on the eye, it's going to stick and it's not going to move at all when the patient blinks. So how do we steepen the lens? We can either increase the diameter or decrease the radius of curvature. And let me show you what I mean. So here's a lens with a constant radius of curvature. If we choose two different diameters, one's going to have fit more steeply than the other. Here's a bigger diameter, and you see the curvature that's shown. Here is a shorter diameter, a smaller diameter, and you see the curvature shown. If you look at the contour, you see the larger diameter just looks more curved. That's more likely to suction cup onto the eye than this smaller diameter. If you had an infinitely small piece, it would just be flat, completely flat. So that's one way. Increase the diameter, steeper lens. The second way to do it, given the same radius of curvature, given the same diameter, would be to change the radius of curvature. And you see a shorter radius of curvature in green makes for a steeper lens. So keeping the diameter the same now, that's the shorter radius of curvature. That's the longer radius of curvature. So a patient comes into your office and they wish to be fitted with soft contact lenses. You fit them with the contact lens. They come back a week later. They say, well, my vision's fine, but the lens is uncomfortable. What do you do, doctor? Well, you say, I take a reciprocal. No, wrong. You say, well, I would sit the patient in a slit lamp and have them blink to evaluate the fit. Oh, okay, well, you set the patient in the slit lamp, you have them blink, and you see that the lens moves excessively. Ah, the lens moves excessively. That means it's too flat. It needs to be made, we need a tighter fit. Well, how do you gain a tighter fit? Well, I would either increase the diameter of the lens or I would decrease the radius of curvature of the lens. If the lens has if a contact lens, hard lens is very high minus, then the edges can get caught under the upper lid, but they can be beveled down so they don't get stuck that way. And if lenses are very, very hyperopic, then the edges are too thin and they can drop too low, but you can have them give a little flange there that's called a minus carrier. That's kind of advanced stuff, but just mention it. So then the patient doesn't want contact lenses. They want refractive surgery. So obviously it's beyond the scope to go too far into refractive surgery. I just want to describe some of the optical principles behind refractive surgery. So the basic idea here is what are we doing to the cornea to change its refractive power? Well, one thing to consider before we even get into that is to recognize that the cornea has spherical aberration, which means that, but some of that spherical aberration is actually complementary to what's in the lens, and so you end up, they can they can actually work together to reduce the aberrations in the eye as a whole. When you change the aberrations of the cornea, you can actually increase spherical aberration of the eye as a whole. The other thing to consider, as we mentioned earlier, is the cornea has a front and a back surface. And so sometimes if you change something to the front of the cornea but destabilize it, you may also change the curvature on the back surface, and if you don't take that into account, you can end up with surprises. So what are we doing what was done when radial keratotomy was performed? Well, in that case, the eye's too strong, so these cuts were made in the peripheral cornea, which caused the periphery to actually get steeper. It destabilized the periphery and flattened the center of the cornea to reduce the power. Astigmatic keratotomy, you cut the periphery here to, again, destabilize the periphery and flatten the center in this meridian. More often now, of course, we're doing procedures to sculpt the cornea to its desired shape. So the basic idea in LASIK, or PRK for that matter, is that we're basically flattening the front surface of the cornea, increasing its radius of curvature, reducing its power, and reducing the correction. In hyperopic refractive surgery, something's being done to sculpt the periphery to make the center steeper. So that's a little harder to do because you have to take away tissue from the periphery to make the center steeper. Another way to achieve that, to make the center steeper, is conductive keratoplasty, where the periphery of the cornea is burned and you get this constricture, this tightening of a band around the periphery of the cornea, and then you get a compensatory steepening in the center. For astigmatic refractive error, you have to reduce the amount of, you have to ablate different amounts in one meridian than in another. And in order to do that, one way to achieve that, among others, is to use a mask over the eye so that you're ablating part of the mask before you get to cornea in one meridian, but not the other. So what happens when you do refractive surgery? Why do you get these optical aberrations that cause problems, and what are they? Well, we go all the way back to the beginning of the lecture from this morning, or was it yesterday? You can get diffraction of light, which is when the light passes through the apertures or across or adjacent to that radial keratotomy scar. And that diffraction can cause like a starburst sort of a pattern. You get scatter of light, and that can be caused by a hazy flap surface, that irregular ablation. You get the irregularity, so light's going to scatter. You can get multifocal corneas, so like a fly's eye, you get different optical zones within the pupil, and that's going to give you different separate images that can cause patients some great distress. Larger optical zones make it less likely that you're going to have a multifocal cornea at the end. It used to be a bigger problem. You can get coma if you have an off-center treatment. Coma is like a comet. The light flares off to one side more than the other. And you can get spherical aberration. Remember, I said the eye already has some spherical aberration, but the spherical aberration of the cornea somewhat works against the spherical aberration of the lens so that the two kind of add up. And so if you take that away, then you can get more. And that can cause halos around objects. So a lot of that can be reduced by doing customized ablation that looked at the whole optics of the pathway all through the eye on a double pass through the eye, wavefront optics. And then you can break down all the aberrations of cornea and lens into spherical, cylindrical, and irregular components and treat in that way to try to make super eyes that have no aberrations. So finally, in this section, I want to talk about intraocular lenses and the power calculations that go with. And you're hanging in there, so we're going to, then we'll take a break after intraocular lenses. So there are theoretical formulas and there are empirical formulas to IOL calculations. The theoretical formulas are derived from optical principles, and in those formulas, the effective lens position is critical. I keep hammering on that, effective lens position. Where that lens is in the eye is key. The older formulas were not very good at it. The newer formulas are better at it. But because the older formulas were not great at figuring out where the lens ended up, we ended up relying on the empirical formulas. Those don't rely on the schematic eye. It's just Saunders, Retzlaff, and Kraft, SRK. They did a whole bunch of cataract surgeries. They measured the axial length, the keratometry, and the lens power that went in, and the outcome, and they plotted it and put it in a computer and calculated a straight line regression curve, and out came their SRK formula of A minus 2.5 times the axial length minus 0.9 times the keratometry gives the power needed for ametropia. The A constant depends on the lens that you're using. It actually depends on the lens position, the effective lens position. And then this is the axial length and the keratometry. So this is a simple formula. You can do it by hand, and 90+% of the time it's accurate. You do run into problems, though, if you get short eyes or long eyes, because it's no longer linear. There's a linear range, but short and long eyes, you begin to get errors, and especially in short eyes. So SRK was modified to the SRK2. Still simple enough. You just add 1 for axial length 21 to 22, 2 if it's 20 to 21, 3 if it's less than 20. So the shorter the eye, the more you add to the A constant. Long eye, you take a little bit away from the A constant. And that gives you even more accuracy, maybe 95, 93% of the eyes, something like that, 95%. So for the most part, that SRK2 is all you need. But for very long and very short eyes, you really need to move then to the theoretical formulas, which have gotten much better now that they're better at predicting the effective lens position within the eye. And that includes the SRK-T, T for theoretical, the Holiday, the Hoffer-Q, there's others out there. You have to use a computer to get the numbers, but most of the A-scan units now have those built in. So you'll get something out that's one of the theoretical formulas. And you especially want to look at those if there's a discrepancy, if you have a short eye or a long eye. I'm a surgeon, you say. I don't care about optics, and I don't want to study IOL calculations. So sue me. So yes, you can get sued for doing a bad job on your intraocular lens calculations. In the suits that I've been aware of, one of the key problems was that there was a failure to measure axial length in both eyes. Because if you have a patient who has the same refraction and the same keratometry measurements, but yet the axial length is 2 millimeters different in one eye than the other, well, then you should see 6 diopters of difference in refractive error. And if you don't, then maybe there was an error in your axial measurements. Now, maybe not. Maybe the lens is hard or something, something else. But at least it should be checked and looked at and considered. And when I used to help residents in cataract surgery, every now and then I'd stop the case because things weren't adding up, and we'd redo the axial length measurements before we'd start the surgery. The other place that I've seen that I've heard of is when the patient didn't have the contact lenses removed before the keratometry was done, because that can flatten or change the corneal power by about a diopter. And the recommendations vary on this. Some say at least 2 hours, some say 2 weeks. For refractive surgery, it's more like a month. But it's only a diopter. Probably it led to a suit because the patient ended up off by just enough that they had to have a lens exchange, and then they had a complication from that, something like that. The most egregious case that I've seen, it wasn't a case actually, but it was just a case I heard about, was a new technician measured the keratometry with the contact lenses still in the eye. So that gave a big error and led to an IOL exchange, but not a lawsuit. So it's diopter for diopter when the error is in keratometry, but a millimeter of error in axial length gives a 2.5 diopter error in the refraction. So axial length has to be measured carefully. And again, SRK alone isn't going to do it if the eye is less than 22 or more than 24.5 millimeters long. So what we've covered then in this second section is visual acuity testing, refractive error, accommodation, astigmatism, and then correcting with contact lenses, refractive surgery, and intraocular lenses. So I think this is a good time to take a break. In our next section, we'll be talking about other optics of note.